My name is Shaun McCann. I'm conducting a series of expert interviews for the European Hematology Association at the annual meeting of EHA, which this year is in Amsterdam, which of course is in the Netherlands. And with me I have Dr. Anita Rijneveld. You're very welcome indeed. I hope I pronounced that reasonably well anyway. And she is a hematologist from Erasmus Medical Center, which is in Rotterdam, which also of course is in the Netherlands. And she's an expert on ALL, BCR-ABL1-like ALL. So my first question would be, I mean, I've known all my life that ALL in adults and ALL in children were two different diseases. We didn't know why until quite recently. So can you explain why they're different diseases, or are they different diseases?
Well, I'm not sure there are different. It is so different. The thing is, the subdivision is different. So in children, you have a lot of good prognostic subgroup, RUNC1, PBX1, while in adults you have BCR-ABL,
right.
You have MLL, and that's far more common in adults. And these have a poor prognosis. They are hardly seen in children. So I think it's a more kind of shift to more aggressive disease in adults, to aggressive forms, which can be seen in children, but are not so often seen.
Right. But the incidence of BCR-ABL in adults goes up with each age cohort. So have you any explanation for that?
Ah, that's an interesting question. I don't know why, no.
But can you speculate?
Well, probably in children you have, it depends on the age.
Yeah.
So it must be an acquired abnormality, because in adults it can't be that it already existed since birth.
Yeah.
While in children you have, of course, a different sequence of acquiring genetic events and eventually getting leukemia, and that must explain the difference in types of ALL between the two age groups. But why BCR-ABL is, how that works in this context, I don't know. But that basics, what I said, are this acquisition of genetic events which differs between children and adults for sure.
And this is the same all around the world? I mean, in Asia and Western Europe, it's the same increase in BCR-ABL in adult ALL?
Yes, yes.
So it's not confined, confined to Western
there's
Europe.
not a big difference. So all over the world, adults have more BCR-ABL positive patients than children, absolutely.
Okay. Now, we've known for many, many years, before you were born even, that adults with ALL did very badly, okay, until we found this. So the BCR-ABL, gives it's a bad prognostic indicator in adults with ALL. Is that a fair thing to say? I mean, before we had TKIs.
Well, yeah, exactly. So that is the difference.
Yeah.
That is the point.
Okay.
So, well, basically the outcome in adults is all over worse than in children. So that's a general thing. So in children the outcome is around 90% overall survival. In adults it depends on the age group. So under 40 years of age it's around 60 to 70% nowadays, because we adopt treatment from pediatric regimens.
Yes.
While in people over 40 years of age, there's not a lot of improvement by increasing dosages. And that is due to toxicity more than due to aggressive disease.
Yeah.
It's more toxicity, early death. An early death rate in adults around 10 to 20%, mind you. So no way you can improve treatment by increasing dosages.
Right.
However, if you talk about Philadelphia positives, I think it's wrong to think now that these Philadelphia positives are the worst group now.
Right.
Because by introducing TKI, imatinib, it is improving.
Okay. So we need to know how to use these drugs and when to use them. So do we use them for induction therapy or do we...
TKIs?
Yeah.
All over.
Well, talk to me about the protocols for TKIs.
TKIs we use from Well, the best is to start the day you know a patient is BCR-ABL positive.
Okay.
To go on till allogeneic stem cell, and even 1 year thereafter. When a patient becomes MRD negative, you can probably stop. So that is in the case of allogeneic stem cell transplantation. And I'm advocating that you should transplant these patients, because when they do relapse, the outcome is very poor.
Yes.
So take all the advantages you can get in the first line, I would say. So that is in allogenic setting. But when a patient is not eligible for allogenic stem cell, I think you are brave when you want to stop your TKI ever. So if you get a patient to your remission, I would say go on with the TKI till
indefinitely.
Yeah.
Yeah. Okay. So that's a pretty big commitment by a patient, isn't it?
Yeah, absolutely.
Stay
That's
on
true.
that
That's
forever.
true.
I mean,
yeah, but if it comes back, you don't have a
you
lot of
die.
Exactly.
Okay. And of course, allogeneic transplantation is going to be limited very much by the age profile.
Absolutely.
So what age is the cutoff? I'm too old, obviously, for one.
Yeah, that's absolutely right. So the cutoff it differs a little bit per country, per center.
Yeah.
In the Netherlands, the most centers do 70 years. So till 70 years.
I still wouldn't make it.
Okay. So if a patient is above 70 years, you don't offer a transplant. And if it's below 70 years, of course you have to be eligible for it and fit.
The role of haploidentical transplantation,
yeah,
can you comment on that?
Yeah.
Because everybody has a donor then.
Yeah, but I'm not a stem cell transplant expert, so I don't dare to discuss haploidentical.
Okay, fair enough. Okay, I mean, there are many different TKIs now available with increasing pressure to use second generation ones. Do you have any preference for the TKI you use, or is there any difference?
That's a difficult thing, because we don't have phase 3 studies comparing the different TKIs.
We never will, probably.
No, they will never come. So we cannot say. We can only say that the most studies have been done with imatinib. Okay? Around 30 to 50% reach complete molecular response. There are, let's say, 5 studies done with dasatinib, even less with nilotinib, and a few with 1 or 2 with ponatinib. So the complete molecular response rate does not differ that much.
Yeah.
Only ponatinib.
Well, that's only in specific mutations. Yeah.
No. Up front now, there's very recently the Americans published a study in which ponatinib reached in CR in 80 to 90% of patients.
Okay.
And that's impressive.
Irrespective of the mutational
Irrespective
status.
of mutation up front.
Okay.
But coming back to your question, which TKI, you have to bear in mind, although the complete molecular remission rate is not so different between the different TKIs, the amount of mutations which accumulate after treatment with TKI is higher with the second generation TKIs than with imatinib. So I myself am in favor of imatinib, because the resistance pattern is better. And as I said, you should consolidate with allogeneic stem cell transplantation anyway.
Right.
But of course, there are also advantages to the second generation, which also target other targets like SARC and might be of use. So that you can choose, but my preference is imatinib.
Imatinib, good. Because in this age group, toxicity profile is very important.
Yeah, absolutely.
And we've known about imatinib for now almost 20 years. So
Yeah.
we have a very good feel for things that can go wrong. So
Yeah.
would you agree with that? I mean, the toxicity profile from dasatinib and nilotinib is much different than that.
Oh yeah, absolutely. But that's true. So, but all have their different advantages and disadvantages, and in combination with chemotherapy, it's even different. So you just have to try. It's mainly trial and error, I think. Yeah.
And the role of steroids at diagnosis in adult ALL, does everybody get high-dose steroids initially?
Yeah, because you want to reduce your cell count to prevent massive tumor lysis.
Right.
So normally you do a pre-phase with steroids, and then you start your remission induction treatment with chemotherapy.
Okay. We'll just go back and talk about MRD for a minute, if I may. There are two definitions. One is minimal and one is measurable residual disease. Which camp are you in? Minimal or measurable?
Minimal. Yeah.
Minimal,
Yeah.
not measurable. I mean, it depends on the sensitivity of your technique, doesn't it? I mean, if your technique is very sensitive,
Yeah.
you'll always find
Yeah, that's
minimal
true.
residual
Yeah.
disease. So it's really measurable, but
Yeah, probably you're
I
right.
think that's, well, that was the late John Goldman's, it wasn't
Oh
my
yeah, I
idea.
don't
Yeah.
know. No,
Yeah,
but you, yeah. Now you explain, yes. I agree. Measurable disease is better. Yeah.
I think it is probably, yeah, because as I say, it'll vary a lot, and we'll change the definition
Yeah.
of MRD as we get better technology.
Yeah.
So,
Yeah. True.
it's a movable feast, as we would say.
Yeah.
The other sort of hoary question, if I might say so, is cost. The cost of TKIs is very high.
Yeah.
Can you comment on that?
Yeah. It's true, but you save lives. And I think, especially if you talk about costs, the continuous administration, as I mentioned, might be a problem. You
Yeah.
are right.
Yeah.
But yeah, it's a difficult discussion and a long discussion. But to be short, I think when patients get a relapse, okay, nowadays,
Yes.
you give very expensive drugs to save their lives, like blinatumomab, like inotuzumab ozogamicin, like CAR T cells,
And they die anyway.
and they die anyway. So in that
Okay.
respect, I think upfront TKI for a long time saves a lot of money.
Okay. Let's just talk about low dose toxicity in, if you're taking TKIs forever. I mean, compliance is an issue
Absolutely.
in chronic myeloid leukemia. Is it an issue in patients who
Yeah.
have ALL?
Yeah.
And how do we get over that?
Yeah, well,
Or do you have any ideas about that?
well, you have, if you talk about compliance, the worst group, of course, is the young adults,
Yes, adolescents, yes.
And
They comply with nothing.
exactly. and we are not so much aware about that. Of course, in countries you do have young adolescents clinics. We don't have. In our hospital,
We don't have adolescent medicine, yeah.
And they have specific people like social workers,
With
like
an interest,
psychologists,
yes.
who are aware of the problems these patients have.
Yeah.
And for us, adult doctors, we don't have that
No,
experience.
but what we do have is we have patients who have grade 1 toxicity, but if they have it for 10 years or 5 years, it gets very debilitating, although we don't consider that
Yeah,
as
I
important.
agree. I agree.
So we should listen to patients more often, perhaps.
Yeah, we should. But on the other end, what's the other option?
I suppose if they, it's a bit like hypertension. If they stop their tablets, their blood pressure goes
Exactly.
up. So,
It's exactly the same. So you should have an open discussion with your patient.
right,
It's their life.
Yeah.
But you have to be clear on it.
okay.
And they might stop, yeah.
They might, in spite of your best efforts.
Yeah.
Well, listen, thank you very much for sharing your thoughts on this
Okay.
interesting disease. So for young investigators, the whole spectrum of adult ALL has changed in the last 10 years. And with the advent of TKIs, of course, the prognosis has gone from very bad to quite good.